as we go along. So hi and welcome to another one of our webinars in our series. Tonight's webinar is around diabetes and pregnancy. It's all a part of our Including Me series, and the series is to provide information, resources and support for all communities across Cheshire and Merseyside, discussing key health priorities to improve women's health. My name is Danny and I am one of the community engagement leads for Cheshire and Merseyside's Women's Health and Maternity Partnership. And here with me today is my colleague Decca. Would you like to introduce yourself?
Hi, I'm Decca. I'm community engagement lead with Danny at Cheshire and Merseyside Women Health Organization.
Brilliant, thank you. And on our panel today and our speaker today, we've got the amazing Dr. Dabika from Countess of Chester. Would you like to introduce yourself?
Hello everyone, I'm Dabika. I'm one of the Obs and Gynae consultants in Countess of Chester. So I do the gestational diabetic clinic, and so perhaps that's one of the reasons why I would be interested to sort of discuss and have an open conversation about diabetes in pregnancy.
Amazing. Yeah. Thank you so much for coming. Thank you for your time and welcome everyone. Just a little bit of housekeeping. If you can keep yourselves on mute just while speakers are talking, just to reduce background noise. And if you want to ask any questions, please feel free. We are having a question and answer at the end of the presentation. So please do pop them in the chat or raise your hand. Or even if you can't virtually raise your hand, just put your hand up and we'll come to you and make sure that we can answer any of your questions. So Dabika, would you like to begin? Thank you.
I'm going to share my screen first. So let's have a look if you can see it. Are we all able to see?
Yeah.
Okay. Right. So what we're going to talk about today is diabetes and pregnancy, and it is a very, very vast topic. So I've got about 10 minutes to squash it into. So is that right? I think I've got about 10 to 15 minutes to speak about, isn't it?
If it goes over, it doesn't matter.
That's fine. It's all right. So what I'm trying to do is try to say what it means actually, and that's the most important thing. So the first thing that I want to say is when we go to our clinic, I keep on hearing things about, this is a silly question, may I ask this? You know what, I know, perhaps I don't know. So the pregnancy is about you and your baby. No question is silly. It is not easy to be said that you've got a condition. It's quite daunting. So you're always welcome to ask questions, and that's why we are here for. Okay. So today's discussion is going to be based on these things. So as we all know, that diabetes can be pre-existing, which is type 1 or type 2. And the other one is gestational diabetes, which happens for the first time in pregnancy. And we're going to just talk about the basics of all things, and you're going to, talk about who, why, what, how, and when. So we're going to answer these questions, and we'll know about what happens in diabetes and pregnancy.
Sorry, we can't see presentation that you're going through the slides. We can only see the kind of the bit before you put it onto presentation screen.
Okay, so I'm sharing the 1 minute. Can I just go back to it then? 1 second. Let me, can you see it now?
Yes.
So let me sort of go back. Can you see this now?
Yeah.
Right, I'm going back. So this is what I started with, to say that when women come to our clinics, they are very confused, and no question is a silly question, because pregnancy is a time when you're very sensitive and your mind is confused. You want to know about you and your baby, and you can ask any question at any point. Okay. So our discussion will be based on these things. So it's either pre-existing type 1, type 2, or gestational diabetes. And you're going to answer these questions: who, why, what, how, and when. And that's going to give us most of the answers. Can we see it now? Yeah?
Yeah,
okay.
We can see it now. Thank you.
Okay, thank you. So the first topic of discussion will be GDM, or gestational diabetes as we call it. And the first thing that I want to mention is it's not your fault. So don't suffer from a guilt if you have GDM. It can happen to anyone. Any pregnancy can be affected by GDM. But yeah, there are some risk factors, and that's why there is a screening service which is offered in the NHS according to our NICE guidelines. There are some women who are at a high risk of getting it. They're the ones who's got a BMI above 30, previous macrosomic means very big babies weighing more than 4.5 kilograms, if you've had a previous gestation diabetes, a family history of your ethnicity background, which is more prone to have diabetes in pregnancy. So we offer you the screening test. The next is, why have I got it? So it's a gift of the placenta, we say. So there are many theories, but we don't know exactly what is causing gestational diabetes. But sometimes there have been some mention about it is placenta is a steroidogenic state that produces more steroids, and it's needed for the growing baby. And also there is sort of insulin resistance going on, and that is why you have the GDM. So there's nothing that you have done wrong really to have got this condition. So what happens now? So that's the first thing that comes to your mind. Like, I've got GDM, I've been given this diagnosis, so what happens? So before this, what happens now, I just wanted to mention, if you're having the screening test, what actually happens in that is we offer you a test called an oral glucose tolerance test, and which is usually done around 26 to 28 weeks of your pregnancy. If you've had GDM before, we would like to do it earlier, around 16 weeks. So you come in, we do a fasting blood test, and then we give you a fantastic sugary drink and repeat your blood tests again in an hour or 2 hours from then. And that gives us some cutoffs from where we decide whether you have the condition or not. And if you have GDM, then most of the times, you know, you wouldn't have any symptoms at all. It's just a finding that we have found it because you've been tested for it. Very occasionally, sometimes you can feel a bit unwell because your blood sugars have been playing up. It may be that you went for your antenatal check and your midwife measured the baby to be too big, or you're feeling very full of baby and, you know, your tummy feels a bit more distended than your period of gestation. That's because sometimes you can have molica, so there's a condition called polyhydramnios. Or maybe when we're dipsticking the urine sample, it's showing plus of sugar. So that's called glycosuria. So that's what, you know, happens actually. And then comes to your mind, what are the risks of this condition? So the risks can be something to do where you are involved, your health in general, or the risk to the baby. Now, there is a correlation. If you have diabetes in the pregnancy, there's a higher chance of you getting a hypertensive disorder in pregnancy as well. So we monitor you together. You can have a baby, which is very big. Sometimes babies can be small, but most commonly they're big babies. Polyhydramnios, as I mentioned, is a lot of water around the baby. So this has an impact on to your birth time. So when you're going to go into labor, or when we're making plans for your delivery, so we may have to get this baby out before your due dates. We usually wouldn't go past or beyond your due dates with a GDM. We do go up to about term plus 5 maximum if everything is well controlled, but not too much beyond your due dates. So you may be offered with an induction, that's the IOL, or maybe a cesarean section if your baby is too big. There is a condition called shoulder dystocia, which most of you have heard about. It's to do with the vaginal delivery of babies, when sometimes the head is delivered, but there is problem with delivering the shoulders. It becomes a bit of an emergency, and it's not a very good thing to happen because there is grave consequences of the baby if not delivered in the right time. So basically, a lot of planning now has to go in as to how the pregnancy goes forward and what's going to happen during the childbirth. Once the baby is born, there is a risk of baby having hypoglycemia the other way around. So the next question that comes to our mind would be, how do I keep myself and my baby safe? So that's the whole idea of having and offering you a proper antenatal care. So once you've been diagnosed with GDM, if you were in a low risk midwifery care, your care will be now transferred to a consultant-led care. So it's a team actually working with obstetrics as well as the diabetic team. Some units have both of the consultants together, and some of us actually have just an obstetric clinic and the diabetic clinic separately, but we all actually in the background work together as a team. But the most important message that I want to give is most women will have a healthy pregnancy and will have then deliver healthy babies. So though we consider this to be a high risk, but if managed and looked after well, the consequences and the results are all very, very good. So you have to test your blood sugars, blood glucose monitoring. It's the key to the management of diabetes and pregnancy. And it's very, very important that this is done. It's not pleasant. It's not pleasant to be doing blood tests, doing those pinprick tests many times a day. But that's the most important criteria, the most important test that we need to know. We need to know your sugar levels. Nowadays, there are many apps which are possible and you can download on your phone. Usually the diabetic team would have, and they will let you know once you've been given the testing kits, you will be allowed to then given access to those apps, and you can all put it on those apps and they give you readings. They track what's your, how your sugar levels are behaving, and then we can work out what sort of support you really need. The commonest thing that we start with is dietary modifications, and I'll come to that in a minute. It's very important staying active. You can still continue with your exercises, anything that you were doing, just a healthy lifestyle, as we say, and that doesn't stop because you have diabetes. In fact, we encourage you to do that as much as is comfortable for you, and it's safe to do in pregnancy as well. One thing we cannot but stress is mental well-being. It is a stressful time. Pregnancy is a stressful time. We blame it on the pregnancy hormones. And on top of that there is a condition. Now and diabetes is a big thing. Whatever you say, even if it's a gestational, the word diabetes, I think, carries with it a bit of scare and a bit of worry to most of us. So, we might be more stressed, and that will increase our blood pressure anyways. So what we want to say is, look after yourself, talk to people. There are lots of support groups available. The midwives usually are very good to talk to. And, there is always a team who's willing to speak to you and answer any questions or whatever comes to your mind. And finally, there are some medications which we offer. Most of the women will just need dietary modifications, and that's all that they need. But sometimes, because we want the blood glucose levels to have fixed targets, we wouldn't let you just carry on if that's not helping with your diet. We would put you on medication, and we actually usually start with oral tablets. And if that doesn't help, we start or move on to insulin. So that's what happens. Now you will expect quite a few visits to the hospital, some to see your midwife and some to see the obstetric consultant, as well as the diabetic team. What we usually would do and recommend is growth scans, and those growth scans are done every 4 weekly from 28 weeks onwards. That's to check the growth of the baby and gives us an idea as to how big or small the baby is growing, to have a better planning about delivery. So I was talking about this diet. Now, it's very hard to just stop eating everything. So most of the times, the diabetic team will put you across to a dietitian, and they sort of work out an individualized plan for you. It's okay to have a little bit of, cake or something which is rich in carbohydrates. But on an overall, we try to restrict the carbohydrates. So things like moving from white bread to brown bread, cutting your rice and going into something more healthier, stopping all the sugary thing. Now, what was remarkable to know is, a lot of us get sugars from our drinks. So this is a new concept. Now we are all going green and going green for the environment. So we can also go green for our drinks. So we can actually cut a lot of sugar intake if we move from our drinks to non-fizzy drinks, water, milk. And that's a very good start, actually. So the dietitians are very helpful. You can have a few bad days or a few naughty days, I'd say, if you've got a birthday or you've got some, Christmas time or any festival time, we all would like to eat and enjoy. You're allowed to do that. I mean, overall, if you're good, 1 or 2 days or a few meals where you just, you eat or do something and take something with extra carbohydrate wouldn't really upset your overall glycemic control. So you're still allowed to eat a little bit and keep yourself happy. So the next question is, when will I be cured? Now, diabetes in pregnancy, or GDM, is a condition which happens only during the pregnancy. So the cure is actually delivery. Once the baby is born, you don't need any support to do with your medications. So if you were on metformin, it stops then. If you were on insulin, it stops there and then. So you're actually cured of the condition once the baby is born. But the next question is there any future risk? Actually, there is. So the future risk of developing a type 2 diabetes in the rest of your life increases if you have this condition in the pregnancy. There's also a risk of having it again in your future pregnancies. So what happens is 6 weeks after you have delivered, so that there's a postnatal check, and we usually would repeat your fasting blood glucose levels, and annually your GP will arrange a blood sugar testing to just see whether you're getting this condition, not the GDM, but the type 2 adult type of diabetes future in your pregnancies. Okay. So now we move on to the other category, which is the pre-existing diabetes. So if you already have diabetes and you are now thinking of getting pregnant, what happens? Now, most of you would have already, by this time, you know what is right for you, you know what medications you're doing, but we cannot stress the importance of planning. So here the who, whys, and how is going to be a bit different. Our why here is why planning of pregnancy is so important in pre-existing diabetes. Now, good glycemic control is very important, and we have good strict target levels. We want our HbA1c, which sort of monitors our sugar levels over the last couple of months, to be at a low. We want to see that our eyes or retinopathy or any condition with the kidneys are okay. We would like to review what drugs we are on, because some of the medications which are used for control of diabetes outside pregnancy is not suitable for pregnancy, because some of them have teratogenic effects. So we want to also explain to women, and that's very important. I've taken the last few sentences from our NICE guideline, which says that if you have a good glycemic control before your pregnancy and conception, then it reduces the risk of miscarriage, congenital malformations, and neonatal deaths. The risk is not completely eliminated, but clearly reduced. So that is the importance of planning, actually, before we start a pregnancy. So what are the risks in this type? So the risks are, some of it will merge with what we've already discussed, but some of it is different because this is a condition you've already had before. So the challenges of blood glucose control, because you are used to a certain type of meal, you're used to a certain type of targets, but it all changes due to the physiology of pregnancy. Things like morning sickness, when you're vomiting, you're not feeling well, you're not taking your food well. So that early pregnancy can be a very tough time to control your blood sugar levels. There will be sometimes maybe we give you steroids to increase the lung maturity of the baby if we're thinking of delivering the baby earlier. So again, steroids will upset your blood sugar control. Now, again, the risks are of babies being big, the risks of shoulder dystocia. So we have to rethink about birth options. With pre-existing diabetes, we usually have a target to deliver between 37 to 38 weeks, and sometimes even earlier. So the risk of iatrogenic or, we induce preterm birth, that might be an issue. Some women are very worried about breastfeeding. It's actually safe to breastfeed if you've had diabetes or you're on any medication with diabetes. So these are the things that which come to our mind. So how do I keep myself safe? So we will be in a consultant-led care. We will arrange growth scans. You will be on insulin, and many of you will have insulin changed. So we go on to insulin pumps if your diabetes, if your sugar levels are not being well controlled. So this is a continuous pump, and that sort of titrates and gives you the right dose. Sometimes you need more than that, correction doses. If you have hypos, we need to know how to treat them. It is very important for you to carry some sugary drinks or some sugary stuff, candies and things in your bag. Sometimes, you're not aware that hypos will happen. So your family members need to know if they find you going suddenly unwell, they should be aware that these things can happen. Staying active again is good. And once again, mental well-being. I cannot stress on this because it's very, very important. And it is something which we always like to stress on. So the who and when is again different. So obviously, when will I return to my previous levels of medication is a question which we keep on hearing. So most of you will have some extra doses and extra input during your pregnancy, or even maybe during labor. You may be on different sort of pumps. Most of that will come back to your basal levels once baby is born. And there is also sometimes it comes to my mind, will my baby will be affected in the future? So type 1 diabetes, again, has got a link that may be, but again, the risk is quite low. It's usually around 5%, 7% if both parents are affected. But that's something which we talk about later on, and usually the neonates, pediatrics, GPs follow up. So in a nutshell, I want to say is it is a bumpy ride once you know that you've got diabetes or you develop diabetes in the pregnancy. But however, pregnancy is a wonderful time and there's lots of support. If we sort of diagnose it and we give you all the support, you will have a healthy pregnancy and will deliver a healthy baby. So thank you.
Oh, thank you very much. That was great. Thank you. We have got a couple of questions. We've got one in the chat. Ruqayyah, I don't know, do you want to ask that in person or do you want me to just read it out in the chat for you?
Yeah, please, if you can read, that would be better.
Yeah, not a problem at all. So Ruqayyah's just asked about shoulder dystocia. And asking, is it particularly prevalent in, gestational diabetes?
So yes, so what happens is shoulder dystocia, as I said briefly, is a condition when it happens during vaginal births, when their baby's head is delivered, and then we have problems in delivering the shoulder. I will just say a little bit why it is so important. The importance is because once the head is delivered, we want the baby to be delivered simultaneously. When the shoulders are stuck, there are certain changes which happen and the baby gets distressed. So the problem is we usually have only about 7 minutes between the delivery of the head and the delivery of the baby for that baby to be born in a good condition. Otherwise, the baby sort of gets distressed, hypoxic, and then it can go to an irreversible change leading to hypoxic encephalopathy. So that's our greatest worry. It's a big emergency. Now, shoulder dystocia can happen in many, many situations, and there are risk factors apart from diabetes, actually. And it can happen in uncomplicated, normal-sized babies, non-diabetic moms. But there is about a 15% increased risk if it is a diabetic mom, even if it's not macrosomia. But if the baby is very big in diabetic moms, then the risk is really much more. And that's why we do the growth scans. We want good glycemic controls. And if we think that this estimated fetal weight is going to be rather big, and especially when we do the growth scans, is one parameter. We look at circumference around the baby's tummy, abdominal circumference. If that's big, that's an indication that yes, this baby can be one of them which has a shoulder dystocia, and we cannot 100% predict it because scan itself has got about 10 to 15% error in predicting. And but then if we think yes, we would talk to you about the different options. We would think about getting the baby out earlier because it's towards the end the baby tends to grow even more, and sometimes if the baby is too big, we even offer you a cesarean section. Does that answer your question?
Thank you.
Okay.
And then she's just asked as well, how does the previous baby's weight contribute to gestational diabetes?
So if what happens is if the previous, suppose in your primary pregnancy, you've not had a GDM, but you've just had a big baby, 4.5 kg and more. It can be, it's just a constitutionally big baby. You know, if you have, sometimes it seems that the babies are more long than they are actually bulky, but just to standardize it and so that it doesn't, you know, so that it doesn't slip through the net, we say that it may be that your previous baby's big weight was due to a subclinical GDM, which wasn't picked up. So that's why we want to catch it this time and, you know, sort of manage you as if you were GDM if you came back as positive for the test.
Brilliant, thank you. And Keely, did you want to ask your question?
Yeah, I can do. Thank you so much for the presentation. It was really, really helpful. Towards the beginning, you mentioned about ethnicity and that be a factor on diabetes. Just wondering, could you highlight which?
So ethnicity, yeah, we have Asian, South Asian, okay. We have Afro-Caribbean as well as Middle East. So these are what NICE actually says, these are the high risk ethnicity background. So we would have a GDM testing, screening testing with OGTT offered.
Thank you.
Brilliant, thank you. Does anybody else have any questions or comments?
I have got actually a question. I was writing, but it's better if I just ask it straight away. You know about the ethnical group who are more prevalent. Why is that? What is it? Something to do with genetical or cultural, or just the way of living? Why are these community are more prevalent on the gestational diabetes?
I think it is a combination of all three, but I would say it's more a genetic predisposition. I wouldn't say just lifestyle, but I would say it's more a genetic predisposition, which causes the association.
Thank you. It always takes me back because I have got 3 children, and my third, I had gestational diabetes and was put on insulin. So it was quite interesting listening to your talk, really, because it kind of took me back to all those appointments and all the finger pricking and having to have the insulin and all that. And it just made me realise about the predisposition as well to getting type 2 diabetes later on in life. Because although I've been aware of that, I've kind of, you know, thought about it, but nothing's ever been done. So I've never had any annual reviews or anything, and she's 4 now. So
have you not? Okay.
No, I've had nothing. And I'm overweight as well, so I'm already predisposed to obviously type 2 diabetes as well. So it's quite interesting because it might just make me think about, you know, look into it a little bit more, and just seeing, you know, I don't think I have because I know the symptoms, but it's nice just to understand that, you know, there is a possibility and to look out for it and, you know, looking after. And would you say for those people who obviously are predisposed, would you say kind of treat your lifestyle as pre-diabetic
So,
almost?
Yes, lifestyle modification is the key. And all of us, you know, we have a responsibility. So we always say the diabetes run in our family, heart disease runs in our family, but you know, the actual crux of the matter is that nobody runs in our family. We don't do exercise in our family, and that is what happens. I think that's the most common genetic inheritance we get. So I think it's the same with me as well, you know. So it's very important to look after ourselves. And we've got such hectic lifestyles. We have stress and tension come free in abundance. So we have all the reasons to, you know, develop diabetes, to develop, you know, conditions in our, you know, in our lifetime. And we can see that more and more it's happening to younger people. So I think it's important to take a few minutes out of a day to, you know, just go for a walk, you know, switch over from, you know, the naughty food to good food. And it's not good to just stop everything. I think that's when the binge comes back. So most of us who go into very rigid diets or very rigid, you will see that the weight loss is extremely good in the first couple of weeks and months, and then it just comes back with a vengeance unless and until you're extremely motivated. So I think it's better to go in the middle path. So, you know, you still would go out and eat some things, and, you know, you would do, and you would have some lazy days. But overall, if we can change our lifestyle, change those sugary drinks to maybe more water, simple things, and cut your carbs, take good carbs, get out of the bad carbs. So I think it's very important to have targeted shopping lists, and the one thing that I've noticed is and especially if you have kids, because mums always eat the leftovers, so it's good to have a healthy diet pattern for the entire family. Sometimes we think, oh, kids can have the chocolates and all of that, but we land up eating that as well. So I think it's important that the whole family goes into that sort of diet pattern, and only then can we all stay fit.
Absolutely.
And one thing I would say, Danny, sorry, interrupted, you must let your GP know if that hasn't happened, and they should offer you a test every year, actually.
Yeah.
Sorry, I interrupted you.
No, it's fine. It's good because, like you said, this is what this is for. It's to learn about things, and as a nurse myself, it's something that's always been in the back of my head, but it's never, been done from a healthcare point of view. So it's good to know that, so then I can at my next appointment say, is it time for me to get checked out or whatever? And I haven't got the best diet, so it is something that I need to be considerate of as well. But this kind of got me on, and Keely, I'll come to your question in a minute, because I think part of that answered it as well, in like, the lifestyles and things. But obviously in Liverpool and Cheshire and Merseyside, we're in the top 5 most deprived areas of the UK. So if you think about the cost of food and fresh fruit and veg and things like that, if somebody is diagnosed with gestational diabetes and has to change their lifestyle and their eating habits, is there anything that from an NHS point of view that they can get support to be able to buy fruit and veg and things and kind of get a better lifestyle?
To be honest, I wouldn't, but no. But what I can say is the diabetic team actually will have dietitians, and probably they can channelize better. But even in the most deprived situations, I completely understand. It's not only in with families to do with deprivation, but even as inflation is going up, it's not always easy to buy the food that you would really like. All the brown rice will be more expensive than your normal rice. But small subtle changes, I think bread is a breaker. So bread can be changed, and drinks can be changed. In fact, you will spend less if you stop your Coke and fruit juices and just go to milk and water. So those sort of small subtle changes could be important, and they can help actually.
And that's really good to know, because it is subtle differences, isn't it?
It is actually
a whole lifestyle change.
No, you shouldn't, and it's not possible. You don't have to go for like organic food or anything. It's just that you keep yourself healthy. So instead of having perhaps biscuits, you can change that into something which doesn't have so much of carbs and sugars in it. So those sort of changes would be better. In fact, a pack of biscuit is equivalent to maybe a few cucumbers. So have cucumbers and carrots for snack. It's not always, the money. It is money important, but when we see that you're buying a cake and a biscuit and this, and you put that same bill, we'll probably get some more fruits and vegetables in that. So we can swap around if we would like to.
Yeah, and local markets and corner shops usually are cheaper as well, because they're local farmer produced, so they tend to be a little bit cheaper than your supermarket.
It is actually,
and last longer.
Yeah, they last longer, and you come back with much more greens and healthier stuff than you would actually go to supermarkets and fill your trolley with goodies which are not actually good for your health.
Absolutely. Keely, do you want to ask your question?
Thank you. And I think just to touch on what you were saying, and I think it's about being able to support the person to make those decisions, isn't it? Because sometimes you can go the shop and not realise if you've got little money towards the end of the month, and understanding that you can do that. So that's really good. Just I know that we've been asked this question before, and sorry if you've already answered it, but if we have gestational diabetes during our pregnancy, is our baby more at risk of getting diabetes type 1 or type 2 later on in life as they grow?
No, I mean, not in GDM. No.
Mhm.
But then again, I must say, because it is a lifestyle thing, and some of us, we don't have the right lifestyle. So if we sort of don't control the diet pattern of our kids, then the kids will, be overweight and things like that, and then it'll move on to a different direction. So that's possible.
Thank
It's
you.
all interlinked, sort of.
Yeah, it is. And just looking back at your presentation and what you were saying, I was told when I started my insulin that I would be delivering around 37 weeks. There was no size problem. She was reasonably sized for a gestation. Is that due to the insulin, or is that due to, do you think that was her size? Because I was induced at 37 days.
So usually we say that for pre-existing diabetes, 37 to 38 weeks is a good time to deliver, because I know in your case that maybe you were not. Did you have to up your insulin doses?
Yeah.
So that's a thing, because your insulin dose was, you were needing more insulin. So up to a certain point, we think that's okay. 37 weeks is actually term. So we don't want to continue with that pregnancy beyond that, because we would not get much benefit in continuing. So if we weigh the pros and cons, that's the safest time. Baby has become mature. Your requirement of insulin is increasing. So we sort of strike the balance and deliver. That's the safest time for both you and baby to deliver then.
Does anybody else have any more questions?
I have got one. I've just thought about it. On the website, on the NHS website, it says the gestational diabetic is caused because of the insufficient insulin production during the pregnancy. So I was thinking, does the body need extra insulin during the pregnancy compared to just a normal body
So the
function?
whole concept of GDM is insulin resistance, basically. Okay, so because the placenta is a steroidogenic thing, so the body is not coping. There's a two to four fold of increase in insulin requirement as well. So it's not coping with it. But that doesn't mean that we have to give you insulin as the start point. Okay, the reason for that impairment is causing the GDM, right? However, as long as your sugar levels are being maintained and they're not going too much out of target, we don't have to start with insulin straight away, because diet itself and your lifestyle changes in diet can modify that. So we don't go by insulin requirement. We cannot test we don't test insulin requirement. We test the blood glucose, because that's the indirect way to measure that. So if your blood sugar levels are within target levels, that means whatever insulin requirement is needed, that's being served. However, if that's not being maintained, then we go on to medications, oral first and insulin later on. Yeah, does that answer your question?
Fantastic. Yes, thank you so much.
Defa, do you want to ask your question?
Yes, I was wondering, if someone has gestational diabetes, do they have to have C-section, or they have a choice until later date?
Oh, not at all. So cesarean section is not a mandatory option at all. If you have diabetes, any type of diabetes, a GDM or the pre-existing diabetes, our first choice would be to offer a vaginal birth safely if we could. Okay, so for instance, you are very, very well maintaining your blood sugar levels, you're just needing diet, or for instance, you're needing very low levels of, any medication. Then we will offer you, we can either let you go and do things by yourself, but if you need 2 medications or a large dose of one medication, or you're on the insulin, then we will have to plan your birth. And that even if we're inducing you, that means we're offering you or helping you with a vaginal birth. So it is not mandatory to have a cesarean section. Cesarean section is only needed, if the baby is too big and we think even an induction is not safe, or if we are trying to deliver the baby very early and we feel induction is not going to work in those cases, or if something happens in the middle and we think cesarean section is important, that's when we offer. So it's not a must, not at all.
Thank you, Devika.
You're welcome.
I've got a silly question. The prevalence of gestational diabetic in UK is about 4 to 5%, compared to the global, which is just about the same, 1 in 23, which is about 4%. So is this number high, middle, or low compared to other diseases, especially for maternity diseases, if you know?
I didn't get your question, sorry. Can you repeat it?
So the prevalence of a gestational diabetic in UK is 4 to 5%. Is that high, low, or just?
I think it's more than that. I think it's slightly more. Yeah, more. Yeah, it's about 5%. Yeah. Yeah. So
yeah,
what would you
know? What I mean is this percentage high compared to other diseases, or is just small or moderate? Just to understand.
So, no, other diseases in the sense GDM, say for instance, is actually it's a pregnancy specific disease. Okay, so for it to happen for the first time in pregnancy, 5% or more is a good. It's a high. I wouldn't say it's a low incidence, and the prevalence is increasing day by day. It's not stuck there. It will increase more in the future, because again it's linked to lifestyle. So the more we have big BMIs, the more we have previous GDMs, all that will add on to we're seeing more and more people coming with GDM now, and it will only increase. So I won't say it's a very low possibility. So if you compare it with other diseases, things like what do you want to compare it with, obstetric cholestasis, say, or maybe PET. So these are conditions which develop during the pregnancy. We can only compare it with other diseases which come for the first time in pregnancy. So GDM is more common than the others, if that's what you would like.
Yeah, that's what I meant to compare to other maternal issues. That's what I wanted to compare with. So it's high and it's only increasing. That's even worrying if it's just to continue to increase.
That's where the lifestyle thing comes into thing. So, but then remember that though we can have some risk factors, it can just happen to anyone. So there is no correct answer as to why it's causing it.
Thank you. Just as a side, with diet controlled or metformin, do you automatically, once you've got that diagnosis, become obstetric led, or is that just for the severe, like the?
No, once you have the diagnosis of GTM, you automatically move from the low risk midwifery to the obstetric consultant led care. So that switch happens at diagnosis. But whether we can carry on, with the pregnancy long term, or we will need to, move on to diet only or modify to other medications, it's a team decision. That's individualized care, but you will automatically move on to a high risk pregnancy. But saying that, even if it moves on to an obstetric-led care or a consultant-led care, if everything is, it's basically to monitor the pregnancy, to see that you're safe. If you're not needing any help with any medication, diet is just doing the wonders, your baby is growing average, not too big, not too low, then we carry on with as much as we can. We go about to term +5 because we don't want to go any much beyond that. There is a small risk of the baby not being well after that, so we don't want to carry on forever. And we can allow you to even have a water birth, so you can have that. We can allow you to do that. But the care would be in a consultant-led care, because the condition is riskier. Anywhere around that, your journey in the pregnancy, things can take a different turn, and that's the reason why we want you to be monitored.
So will it affect home births and things like that, or if everything's okay, they can still have a home birth?
We are still wanting a hospital birth rather than a home birth, but we can allow a water birth, not always a land birth, if you can. That's what we would say. Yeah, because you know why? Because the babies have a risk of hypoglycemia. So we want to monitor the babies. The babies will need attention as well. So that's one of the reasons, again, why a home birth is, something which we don't really want. We want delivery to happen in hospital setting.
You want both to be safe.
Yes, that's the whole idea.
Before we finish off, is there any more questions or comments or anything from everyone?
Yes, I was thinking about, Devika, if there is a multiple pregnancy, for example, you are carrying twins and you're diagnosed with gestational diabetes, is it the same?
It's the same thing that we do. So it just adds on to the risk. The GDM risk carries on. But on top of that, you put the multiple pregnancy risk. So that's a completely different risk factors altogether. So any woman who's developing diabetes in twin pregnancies, usually twin pregnancies, we don't carry on till term. So if it is the good type of twins, the DCDA twins, we would offer them delivery anywhere around 38 weeks. And if it is the other type of twins where they share their placentas, the delivery happens much earlier. So it's actually the timing of delivery which changes, and that is more to do with the twin pregnancies. If, for instance, the GDM would affect the pregnancy, as in the babies are growing too big and you have to get them out earlier, that's a different situation altogether. But most of the time, the pathophysiology of GDM will not change. Or even if you have pre-existing diabetes and you have twin pregnancies, it's not that your diabetes will get worsened just because you're having two babies.
Thank you.
So just one final thing before we finish off, then if nobody else has got any questions. If you are concerned that you may have gestational diabetes, or you may develop it if you're predisposed or something like that, who would be the best person to speak to during your pregnancy?
So if you're concerned that, say for instance, you feel that your baby is growing too, your tummy is feeling your bump is too big, or you're not feeling too well, if you have a midwife appointment, then that's the first place to talk to. But then if you're concerned for any reason, in the sense like suppose you're not feeling very well in pregnancy, because sometimes, as I said, if in GDM it doesn't happen too much, but in the other type of diabetes it can be. So there's always a triage where you can call up, and it's always good to speak to somebody. You may not that you don't need to come, but the midwives give you fantastic telephone advice and they would guide you to the right path. So that's something which we would always recommend.
Thank you very much. And NHS choices on the website and 111 are always really good out of hours as well if you struggle.
Yeah. In fact, our COG has got some patient leaflets. The NICE has got a summary, but that's a bit medical. I wouldn't really suggest that. But there are lots of support groups, and NHS choices is ones. Bumps have got lots of information. So I think there's a lot of information, but I would recommend that sometimes too much information can be scary. So you've got to filter it out, and when you come to your appointments, I think it's better to have a face-to-face discussion and have a chat about it, really.
Absolutely. And sometimes write the questions down as well before you go, so you don't forget.
Very important. It's easier for us as well, because we forget to ask as much as you forget to ask. So it's good if you have some questions. It's easy for us to give targeted answers, and it's always good for the consultation. So that's a very important thing, really.
Well, thank you so much, Kate. That was a brilliant presentation and really insightful. So thank you for your time, and thank you everyone for joining.